Hello. All right. So now we are going on to our really big topic, why we're here. What pharmacokinetic changes do we experience as we age? So the first thing we're going to talk about is pharmacokinetic changes in bioavailability. I will tell you in general, these are not usually clinically significant as we age, but we do want to be aware of some potential problems. Remember, bioavailability to get to the systemic circulation, if you're taking the drug orally or by some other routes, depends upon the routes, but for drugs taken orally, it first has to get absorbed into the gut wall, from the lumen into the gut wall. So there's only a fraction of drug that makes it through. It might be 100%, it might be 0%. Then the drug has to make it through the gut wall. Remember, we have P glycoprotein there and enzymes that can metabolize the drug in the gut wall before it even gets to the systemic circulation. So it has to make it through the gut wall, the fraction that escapes gut wall metabolism. Then the portal system takes the drug to the liver. Remember, the liver is full of enzymes that could metabolize the drug again before it gets to the systemic circulation. So we have to think about all three of these steps and what could aging do to alter that. Well, we do know that patients, as we age, we have less ability to lower the pH in our stomach. So the pH in the stomach rises, which could change the ionic character of the drug to be absorbed. There's also a delay in gastric emptying time as we age. So the drugs that are taken orally are going to take a little bit longer to get to the intestinal tract to be absorbed. There's also a decrease in GI motility and intestinal blood flow, which slows it. So there might be a delay in getting the drug to the systemic circulation when compared with younger patients. Although the GI function declines with age, there are sufficient reserves. So the extent of the drug actually being absorbed usually is not altered. But the rate of absorption may be reduced. It just may take longer for the drug to get there. Also, drugs that require active transport like B12, iron. So that most drugs, remember, are passively absorbed, but there are some drugs that require active transport. They may be decreased in their ability to be absorbed because of fewer transporters. Also, let's talk about the fraction that escapes the first pass effect. Remember, that's kind of tricky. A decrease in liver function and mass that occurs with age can decrease the effect of the first pass through the liver. So remember, when we determine the fraction that escapes the hepatic metabolism, for high E drugs, it's dependent upon blood flow and enzyme activity, not upon binding. And we can go into that if you want to remember from 362. But that decrease in enzyme activity can actually increase the fraction of drug that makes it through the liver. This can be clinically important. How about, so that's really it for the fraction for changing bioavailability. How about changes in distribution, and which is really about binding, isn't it? So we have to think about fraction bound in plasma, fraction bound, that should say fraction bound in tissue. Oh, I have to fix that slide, sorry. Percentage of total body water, percentage total body fat, because that's where the drugs are going, right? Either in water or fat in the body. Well, what you can see is as we age, so here's our very early days, that first month. This is not to scale, of course. Here's to that first half a year of development, and then your adolescence, and then as adults. So what we can see, what happens to total body water? We start out as neonates, as I always say, they're kind of a bag of water when they're born, and your total body water declines as far as a percentage throughout your life. And as you can see, as we age as adults, it decreases, and you end up, you're losing your, as far as a percentage, your total body water is falling. Intracellular water, again, increases as an infant and then declines once you are in your adult years. And in extracellular water stays about the same, but body fat you can see increases. So the percentage of fat in the elderly increases. Here's your renal function. Starts out pretty low and gets high and declines as we age. So really there's a shift from being more water to more fat, and you can see here our renal clearance declines. So changes in body composition. So the ratio of lean body weight to fat, there's a decrease in total body water, which is going to affect water soluble drugs. And there's an increase in total body fat. So lipophilic drugs are going to have a larger volume of distribution here, right? Protein binding, albumin decreases with age. We decrease our ability to make it, and it decreases with age. Alpha-1 acid-glycoprotein, on the other hand, remember, is a acute phase reactant. So as you have chronic diseases, especially those associated with inflammation, AAG can increase significantly as we age, depending on the any disease states or other problems that you encounter as you age. So alpha-1 acid-glycoprotein can increase. So albumin will decrease. Alpha-1 acid-glycoprotein doesn't increase with age, but it can increase because of more disease states. Because of this total body fat increase, the lipophilic drugs, you can expect stronger CNS effects with lipophilic agents. So we try to stay away from lipophilic agents that have CNS effects to avoid problems with dizziness and falls and depression, etc. All right. That's it for this one. I'll be back to talk about pharmacokinetic changes and clearance in the next one.